So ready to go? Well, you just say when.
Okay. We're ready to go. Go ahead.
Okay. So, obviously, given all of the, different therapeutics that we use at the clinic, clearly the majority of them involve interfering with signaling within the cells, and most importantly, differential signaling. In other words, trying to target signal systems in the cancer cell that arise as a result of rewiring because of oncogene and suppressor gene mutations. Now, an important aspect of these signaling pathways, which we really haven't discussed, are the existence of feedback loops and feedback crosstalk. In other words, when we do something to a signaling pathway going from the surface of the cell to the nucleus to affect some type of functional change, there are pathways that actually link back from downstream to upstream, and that link from one pathway that we may be targeting to another pathway that we may not be targeting, and that second pathway may come back and target an upstream pathway in the signaling pathway that we're trying to block. So it can become very complicated. And on the next slide, I basically show, what we have been doing with a number of the studies that we've implemented, targeting the PAM pathway. The PAM pathway, PAM is a euphemism, essentially for the PI3 kinase. That's the P, the AKT is the A, and the mTOR components, the M. So the PAM pathway. And, as we have actually, targeted all three major nodal components within the pathway, the PI3 kinase, the AKT, the mTOR, this is a good example to start with. So there are a number of growth factors which can activate this pathway. And once you activate this pathway, in a reductionist view, in other words, just limiting our attention to this one pathway, which kind of explains everything. That's what reductionism is. Once we target this pathway, we basically see in this schematic that looking over to the right, the three cartoons in the right, whether you target PI3 kinase, up on top, or in the middle on the right, AKT, or, towards the bottom, mTOR, what we expect to do is to interfere with the signaling that will result in cancer cell proliferation, cell survival, and angiogenesis. And we've targeted these separately, we've targeted them in combination, and it's all supposed to work, based upon this. But when you look at it in a more holistic fashion, you go beyond this very limited view that we always have when we say, well, we're going to target this expression of this particular gene because it's mutated, or that particular gene, or this receptor on the surface. Once you go beyond this very limited view of what's happening in the cell, which is represented on the next slide, you can see that there's a lot going on that we have been ignoring. I've put in three rectangles in red, and those are basically, the top one is PI3 kinase, the one just below it is AKT, and the one just off on the left is mTOR. Now, rather than just being a simple 1, 2, 3 approach to the gene that we're trying to block the expression of, you can see that there's a whole lot going on between this particular PAM pathway and a lot of other functions within the cell that are subserved by a number of different signaling systems, and that wind up controlling not only proliferation and survival, but that affect metabolism, affect immune expression, and affect epigenetic control. Epigenetics, being the non-structural changes that actually will modify genes. So the obvious point I'm making is that things are not as simple as we usually think when approaching a specific target in the cell, because we say, hey, PI3 kinase is mutated, let's pick up a PI3 kinase inhibitor, or let's get an AKT inhibitor. And the next slide basically shows that even if we just try to fall back on targeting the pathway, each of these components, PI3 kinase, AKT, and mTOR, behave very differently. Targeting one or the other or the third, the mTOR, doesn't do the same thing. So for instance, in this particular study, DeMarco and his colleagues just took bronchial lung epithelial cells. And what they did for PI3 kinase and AKT is, using a lentivirus, they transfected the cell with a mutated PI3 kinase and a mutated AKT. And in terms of P10, they used a short hairpin P10, a short hairpin RNA, and interfering an RNA interference moiety to block P10, because these are the three most common changes that we basically target within this pathway in the cells. And what's fascinating is, if you look at the blue circle on the right, if you show a mutated PI3, if you transduce a mutated PI3 kinase, that results in expression changes, significant expression changes in 502 genes. Now, these cells, these human cells, have a total of 20,436 genes. So of those, 20,000, approximately 500 genes, you are affecting 502 of those genes. If you look at what happens with the mutated AKT, as pictured in the red, you're affecting 123 genes. And if you look at the green, when you knock out P10, which is essentially a suppressor gene, that's why it's knocked out rather than expressed, you're affecting 1,549 genes. So each of these different changes in the cell, even though they're in the same pathway, essentially is affecting a different number of other genes, both in this pathway and outside of this direct linear pathway. What's very interesting is that when you look at the cells in which you have a mutant PI3 kinase, 327 of the 502 genes. So in other words, 60% of the genes that are affected by the mutated PI3 kinase are not affected by an AKT mutation or by loss of P10. Similarly, if you have a mutated AKT, 44 of the 123 genes that are affected are only affected by the AKT mutation. They're not affected by a mutation in PI3 kinase or in the loss of P10. And in the cells in which P10 is lost, over 1,300 genes are affected that aren't touched when you have a mutated PI3 kinase or an AKT. So when we say, as we did at the beginning, well, we basically can knock out either a PI3 kinase or an AKT and mTOR, just knock out the entire pathway, clearly, each one of these different gene nodes, these controlling areas, have a different pattern of expression as a result of the abnormality. Of the total number of genes affected by all three of these in this model, and there are close to 2,000 of them, only 30 actually are affected by all three. So, one of the goals of getting all the information we get on patients in terms of trying to pick out what we should target by, what's overexpressed and what's underexpressed, we have to realize that there are significant differences in the same pathway depending upon what level you're attacking that pathway. So one question is it the 30 genes that are in common that are the real key genes that we should be attacking rather than the PI3 kinase or the AKT? These are questions that are going to be worthwhile exploring. Now, why are we seeing, this, significant difference within what we say is one pathway in terms of the outcome of, modifying the genes in that pathway? The next slide, presents this concept of feedback systems that has a lot to do with what I was just explaining. There are two major types of feedback system: positive feedback system, negative feedback systems. Now, positive feedback system is when you do something downstream, the result of which, feeds back in a positive fashion to increase something upstream. And the result of that positive feedback is that it enhances or amplifies changes that you otherwise wouldn't see if you didn't have that system in place. That results, of course, I guess this is redundant, in an amplification of the initial stimulation. And by doing this, the system itself, the signaling system, is no longer in equilibrium. It's becoming very unstable. It's all of a sudden it's overproducing. And that obviously can result in deleterious effects. On the other hand, a negative feedback system is a situation where one of the downstream genes or the products of those genes feeds back in a negative fashion to block an upstream gene's expressions. And rather than amplifying the change, this tends to decrease it or generally to buffer it, to put it in a steady state, a state of equilibrium. Now, both the positive and the negative feedback systems can work within a single signaling pathway, such as the PAM pathway, PI3 kinase, AKT, and mTOR, or it can crosstalk between pathways. So you can have crosstalk with these feedback mechanisms between the PAM pathway and the RAS pathway, or the MET pathway, or the pathway having to do with estrogen and progesterone receptors. So even though these are different pathways, these are ways for these pathways to interact. An example of that's on the next slide. Now, this is, a virus infection. And, this virus, which, essentially gets in the cell, can, have different effects on different pathways. And over on the left, the virus is affecting the cells through the toll-like receptors and the RIG1-like receptors. And as you can see, it kicks off, a number of gene changes in this pathway that eventually result in an increase in insulin response factor 3, in interferon response factor 3, which then increases interferon alpha and beta. But there's a positive feedback loop. So when you increase the interferon response factor 3 and you get this downstream increase in interferons alpha beta, the presence of the interferon alpha beta further feeds back to increase the interferon response factor 3. So you now have a significant amplification and increase in that signaling. And if you look over at the right, where you see the green and red curves, the green curve basically on the top is showing you what concentrations you have within the cells of interferon beta without the feedback, the positive feedback mechanism. But when the feedback mechanism is working, look at the amplification you get. You basically get double the concentration of interferon beta production because of an increase in another one of the interferon response factors, which is IRF7, which essentially is IRF 3 in combination. You get this significant amplification effect, and obviously this is this is something we like to have, because when you're infected by a virus, this amplifies our innate immune response. Our ability to produce antibodies against the virus. So this is really a great thing to have working properly. On the other hand, if we want to see what a negative feedback pathway does, let's look at the interaction between the interferon response factor 3, response factor 7 on the left, and ATF on the right. Now, the ATF is basically part of a pathway that involves a stress response, which is actually also very important in cancer. And in this case, when you have an increase in IRF3 and 7, it does increase ATF. But as ATF increases now, unlike the effect we get with interferon alpha and beta, as the ATF4 increases, it inhibits the expression of the interferon response factors 3 and 7. So what this does then is it results in a steady state, because if you get more IRF7, IRF3 and IRF7, which increases ATF4, the more ATF4 you have, the more suppression of IRF3 you have. And when you repress IRF3, you're producing ATF4. So you basically have this steady state. You produce more upstream, which produces more downstream. In this case, it's cross-stream. It comes back and inhibits the principal cross-stream. And you wind up just having steady levels of both right now. You don't have amplification. You don't have a decrease, but you have steady levels of both. So this is how positive and feedback loops work. Let's go to the next slide. So the next slide, basically is also showing that in addition to the feedback loops and signaling systems, having, this immediate effect, you basically treat with an AKT inhibitor. We know it does certain things. There's a dynamic response to inhibition of these pathways, which tends to involve these different feedback loops. And when I say a dynamic response, I mean a temporal response, a response over time. So this is a nice slide. This basically shows, what happens, when you knock out the MAP kinase pathway. And the important part of this is actually over on the right. And you can see there are, 3 different colors. The grayish is hours, the kind of vomit green is days, weeks, and months, and then the pink is months. And initially, when we inhibit a signal, we do get some fairly rapid responses in terms of knocking out expression, and we get some initial effects on some of these feedback loops, which you can see on the bottom. Those dotted red lines on the bottom are negative feedback loops, which are affected, as you basically start, trying to knock out an activated MAP kinase pathway. So those are immediate effects, and they may have, no immediate effect on the cancer cell. I mean, even though we're beginning to see changes, the cancer cell can still go on its merry way doing things because there are no significant adaptive signaling changes present. But then as you move from the first couple of hours when you're beginning to block these pathways and you start moving to, a few weeks to a few months, you now have the cell slowly rewiring itself and shifting to other pathways, allowing signals to get from the surface to the nucleus. These adaptive changes that the cell begins to implement in a response to losing negative feedback pathways. And then finally, you get into a situation where even though you've tried to knock out MAP kinase, as a result of these secondary changes due to the modifications with these cross-current and same pathway feedback, you wind up having a group of cells that, rather than having an abnormal MAP kinase, now are abnormal because it's overexpressing RAS, it's overexpressing BRAF, it's overexpressing elements of the PAM pathway, it's overexpressing, the MITF pathway. These cells are now irreversibly resistant because they're no longer using the MAP kinase pathway. They've now shifted over to use other pathways to allow for, the different growth factors to stimulate the receptor tyrosine kinases on the surface of the cell to be able to just shift around what you inhibited. And this is the problem that we get into, where we may see an initial response, and then over time, because of the longer term adaptive changes to these, subserved by these feedback systems, we wind up with resistance. So next slide. So this is kind of looking at, a relatively, simple, almost reductionist view of the PAM pathway. And this slide basically is showing you in red the different feedback mechanisms. And I'm just going to quickly go through these. If you look over towards the right, all the way to the right is the, a red line that has the number 8 on it. And then you have RAS, RAF, MEC, and then just to the left of that, you have 2 lines with the number 1. So let's start there. We go from number 1, which basically is showing you that mTOR1 and its downstream product, S6K, essentially have negative feedback loops on the insulin receptor substrates 1 and 2, which are upstream of PI3 kinase. Then we move to number 2, which is essentially over on the left, going from mTOR1 to mTOR2. And mTOR1 has a negative feedback on mTOR2. So if you knock out mTOR1, you're going to have an increase in mTOR2. We then go to number 3, which shows a negative feedback from mTOR2 to that same, insulin receptor substrate 1 and 2. So when mTOR2 is functioning, it inhibits the insulin response substrate 1. When you basically inhibit that, you lose the inhibition of IRS. So in a sense, it's a double negative, like in grammar. you inhibit an inhibitor and you wind up actually getting activation. We then essentially are moving from 3 to 4. So we're going up to an area where you see GRB10 inhibiting the insulin and insulin-like growth factor affecting the receptor. We can then, shift over from 4 to the left, where we have, pyruvate kinase C inhibiting epidermal growth factor 1. And we shift over from number 5 to number 6, and we see that AKT inhibits epidermal growth factor 1. And, we then, move from 6 all the way down at the bottom to 7, where we're seeing the MEK-ERK pathway inhibiting also EGF. And this is why inhibiting EGF can be, EGF-EGFR interaction can be very helpful in terms of adding it to inhibiting these other pathways, because you can see that there are a lot of inhibitory pathways. When you knock out other elements of different signaling pathways, you have a pretty good chance that one of the tyrosine kinases receptors that you're going to activate is EGF. And then essentially we go from 7 to 8 on the upper right, where we're basically seeing the MEK-ERK coming back and inhibiting the activation pathway of RAS. And then we go from there to number 9, where we have the effect of P10 on PI3 kinase. And finally to 10, where AKT has an inhibitory effect on FOXO. And why is that important? Because FOXO stimulates a number of other tyrosine kinase receptors, HER3, insulin growth-like receptor, and the insulin receptor itself. It can also affect the androgen and the estrogen receptors. So this kind of gives you an idea within a pathway where we first looked at, these 3 major elements, PI3 kinase, AKT, and mTOR. You start knocking these things out, and there's a lot of feedback mechanisms that are going to be affected that may be problematic in terms of the effectiveness of our therapy. So let's take a look at the next slide and take a look at what happens when we say, okay, we're going to use a rapalog and we're going to knock out mTORC1. So what happens when we knock out mTORC1? Well, you can see from the dotted lines, which are showing that we're knocking out these inhibitory loops, that when you knock out mTORC1, the ovals that are now in yellow, starting with the insulin receptor substrate 1, are now activated. So even though we're knocking out mTOR1, we're activating, because of IRS1 and 2, we're activating PI3 kinase, we're activating RAF-MEK, we're activating AKT. So as a result of trying to knock out the PAM pathway, we basically see how these other pathways, and you can see them, as I said, the ones in yellow that have been upregulated, are now slowly going to be able to develop the capability of bypassing the inhibition that we were hoping to get by knocking out mTOR1. So what do we try to do to compensate for this? Let's go to the next slide. So we say, instead of knocking out mTOR1, we're going to knock out mTOR1 and mTOR2. The problem is that we still get effects on multiple negative feedback pathways. So we still have inhibition of the insulin receptor substrates 1 and 2. We still have an increase in the MEK-ERK pathway. We're now getting an upregulation of the FOXO pathway. So now we're getting an increase in HER3. We're getting an increase in insulin-like growth factor. We're getting an increase in the insulin receptor. So knocking out mTOR1 and mTOR2 gets us over certain hurdles, but it also creates other problems because of the fact that they both have disproportionate control over, inhibitory pathways. So, basically we say, okay, rather than, knocking out these two downstream targets, let's see what happens if we knock down an upstream and a downstream target on the next slide. So on the next slide, we're basically going to be knocking down PI3 kinase and mTOR, both of them, TORC1 and TORC2. So we basically finally, get rid of the fact that we still are increasing the insulin receptor substrate 1, but because we're knocking out PI3 kinase, we are effectively knocking out PI3 kinase and the AKT pathway. Unfortunately, in a number of cells, not all cells, we are still getting activation of the RAS, MEK, ERK pathway. And through FOXO, we're still getting an increase in HER3 and, the insulin growth factor receptor and the insulin-like growth factor receptor. So depending upon the effectiveness of our inhibitor, as we have more and more receptors being activated, we may overflow the inhibition by having a significant increase in, incoming signal that may just overwhelm the inhibition, because we all know there's only a certain concentration that we're able to, one, get in the cell, and two, a certain concentration based upon the dose we can give the patient, and there's a dose beyond which you can't go because it becomes toxic to the patient. So we say, okay, we're doing all these things. We keep activating, the MEK-ERK pathway. What happens when we knock that out? Let's look at the next slide. So when we knock that out, if we do it on its own, as you can see, we're still getting significant problems. We're back to activation of the PI3 AKT kinase pathway. We, still have, secondary problems with RAS, which actually involves other genes which aren't on this slide. So none of these are very likely to have meaningful responses in large numbers of patients. And we do know that many of the patients, if not most of the patients we treat, especially with these, single inhibitors, are effective long-term. That unfortunately, most of the patients treated with discrete inhibitors of the PAM pathway, go on to relapse. So, what basically is the lesson we learn from this? Well, one is that it's kind of obvious that we need a systems analysis, that as we get all this data in about, getting our information back from Foundation and what are the genes that are mutated and, what pathways we should knock out, we basically also have to learn that there are non-mutational changes that will occur when we knock out a pathway due to these feedback systems, and that you can't pick them out as a result of the gene being mutated or amplified. You can only pick them out once you actually treat the cell and you see what changes you are producing in these different feedback pathways, which can overcome the effectiveness of your therapeutic. So let's go on to the, I think, last slide. And in terms of, this targeted precision, medical approach that we all talk about right now, there are really three overriding, groups of approach that we need to take. Over and A on the top left, just the group of, healthcare providers, starting with our patient, but then involving clinicians and researchers, the laboratory, the database, the drugs we use, the pharmacy, that we need to be able to begin to implement precision medicine. And then essentially, let's go down to the bottom B, where, we basically take our team, our clinic team, and the information we have, we put it together, with, the laboratory diagnostics, the genomic and transcriptomic information we have, all the information we have from the preclinical models, and then essentially put it together with, our research end, which is the cancer genomic databases, which we're very much involved in, the variant databases that we have from our previous patients that we can look at, and the experience we have from our previous patients. And all that comes to play with, the data management for precision medicine. But that data management for precision medicine is really becoming more and more a matter of systems analysis, looking at, all the effects that I've just outlined, and not only looking at them in a relatively static fashion, but looking at them dynamically, knowing there are going to be shifts over time. And if you go to see, the message that really is giving us is that using, MAPK inhibition as a targeted therapeutic, that, in addition to trying to be effective by knocking out signaling systems, that, in addition to the approach of trying to knock out multiple signaling systems, 3 or 4 at a time, to try to, minimize this crosstalk that we're seeing and a negative feedback, that we also need to look at combining our targeted therapeutics with other approaches, such as immunotherapy, such as modifying the epigenomics, now that we're learning more about the effects of these non-structural changes, methylation of the demethylation of the CPG islands, and modifications of the non-coding promoters and enhancers of the genes themselves, and then putting all that together with trying to modify the metabolism of the cell, how the cells are using oxygen, how the cells are using glucose, how do we block cancer cells from using glucose, how do we treat cancer cells which have a combination of cells near blood vessels which have a lot of oxygen, and cells away from blood vessels which are hypoxic, have almost no oxygen, because the gene displays are different than all of those. And what we do with our therapies are very much different than the hypoxic and the normoxic cells. So all of this is essentially what we will eventually need to do in terms of targeting.
This is her insurance denying the appeal. I guess Dr. Strauss called and helped with an appeal to get foundation or her insurance to cover it. And her insurance denied his appeal.
We need somebody to mute. I'm finished now, but for questions, does anybody have any questions about all of this? Hello?
Dr. Senzer, I'm trying to see if anyone has any questions. Anyone have any questions?
I mean, okay. I mean, the only, she's going to have to wait till she gets a bill from Foundation.
An official bill from them?
Yeah. The only thing I can have
Okay,
her do,
Dr. Senzer, thank you.
she can write in the comment box and say, I haven't been able to work, or, that's literally the only thing I got.
Okay. Because I think she could afford it. Let me get some.